Hi, everyone. Thanks for joining us today. We're going to allow a couple of seconds for people to start joining the room. Thank you for joining us. This was originally scheduled for May 3rd, and so we're happy you made time for us to hear today's presentation. In a moment, today's discussion moderator, GFAP Director and CHAS Co-Director and Crown Family School for Social Work Policy and Practice Professor, Colleen Grogan, will offer brief opening remarks and an introduction of today's presenter, Neda Laiteerapong, an Associate Professor in the section of General Internal Medicine within the Department of Medicine at the University of Chicago. If you have any questions during this presentation, please hold them till the end following the slideshow and enter them into the Zoom Q&A pane for moderating by Professor Grogan. We also will have the chat function open later on in the presentation. If you want to follow up and find this presentation archived online, you can either go to the CHAS website at chas.uchicago.edu or search for the Center for Health Administration Studies on YouTube. And now Professor Colleen Grogan will introduce today's presenter.
Okay, thanks, Keith. Welcome, everybody. It's my great pleasure to introduce Neda Laiteerapong. She is an Associate Professor of Medicine and Director of Primary Care Behavioral Health Integration in the section of General Internal Medicine. She also has a secondary appointment in the Department of Psychiatry and Behavioral Neuroscience, both at the University of Chicago in the Department of Medicine. She is a health services and outcomes researcher and also a board certified internist who studies translational questions at the intersection of diabetes, mental health, and individualized care. Neda has numerous publications in high-profile journals and a number of really interesting NIH-funded grants. Much of her research focuses on implementing system-level interventions to increase the provision of mental health care in primary care settings. And she has other work as well, but it is our great fortune to be able to hear her talk more about that area of her research, which involves integrated behavioral health. So welcome, Neda. I'm really happy to have you here.
Thank you. I'm really honored to be here. And thank you for the kind introduction. I'm going to share my screen. Okay. So I'll just go ahead and get started then. So I have no relevant financial relationships to discuss. The beginnings of this project were funded from a University of Chicago Medicine Innovation Award. And then I had a research grant, which I'll talk about at the very end from AHRQ. And then currently funded as the Primary Care Behavioral Health Integration Director, the Medical Director from the Chicago Medicine Center for Care Transformation. So my learning objectives today for you all are to increase knowledge about the state of mental health care in primary care settings, increase awareness about clinical innovations to increase integration of mental health and primary care at University of Chicago, speaking specifically about the Primary Care Behavioral Health Integration Program, and then one of our programs that we're leading, which is collaborative care, and then also to increase knowledge about current challenges in the delivery of mental health care in the healthcare system, which you'll see little elements of that throughout the talk. So the outline, I'll start off with an overview of the current state of mental health care access. Then I'll describe at a high level the two major integrated primary care behavioral health models, then describe the program that I lead, the Primary Care Behavioral Health Integration Program, describe several elements of our program, and then describe some new areas of research. So this is probably not news to any of you all, that mental health problems are highly prevalent. In 2017, pre-COVID, mental health problems are estimated to affect 20% of US adults, with some differences by gender, by sex, age, race, ethnicity, which you can see the differences down here, and then the percent on the y-axis, and this is data from SAMHSA. You can see there's some variation. The overall rate's about 20%. Then younger ages have higher levels of mental health problems, up to 1 in 4, and then dropping in the older age groups. Slightly higher prevalence among whites. And then people who've got mixed ethnicity have the highest rate of mental health problems, and then women more than men. So very common, affects many, many people. And then of course, COVID just made everything worse, made very few things better. This Zoom adventure that we're all on is part of COVID as well, which could be a good thing or a bad thing, but mental health problems have definitely increased. These are data from last year showing that 40% of US adults reported struggling with a mental health or substance use problem. So much, much higher. And then among children, things are also challenging. So mental health problems have become very common in children. In a survey of children from using data from 2016 to 2019, 10% had ADHD, 9% had anxiety, 9% had behavioral problems. And among adolescents, 12 to 17, 15% had major depressive disorder, 4% substance use disorder, and 16% had made a suicide plan. So obviously, we are living in a world today with lots of people suffering from problems with their mental health. And then that sort of begs the question of where can you get mental health care in the US? This is a map of health professional shortage areas, which is data that pulls the ratio of mental health care providers, or they also have this for primary care, healthcare providers to the population, and this is at the county level. These are data from 2022, and this is obviously the national data. The dark blue, the light blue is what you want it to be. No part of the county is in a mental health shortage area. Medium blue is part of the county, not the whole county is a mental health shortage area. And dark blue is the whole county is a shortage area. As you can see here, there are very few parts of the US that are not in a shortage area. Basically only the Northeast and the Southern California, this area here, parts of Arizona, a little bit of Alaska, but that's probably related to the number in Hawaii, perhaps. But basically across the whole US, you've got major problems with mental health care access. And then if you look at Illinois and Indiana, basically if you're in the northern parts of Illinois, there is not a shortage area of mental health providers. And then Metro Chicago itself, and that sort of goes into Indiana as well. But then the rest of the country, rest of the states are both suffering except for the area that's closest. I think that's to St. Louis there on the Indiana side, but don't quote me on the geography. I'm not great at geography. So you can tell that, and so, major problems with mental health care access. And that sort of leads to the idea of primary care being the de facto mental health care system in the US. So this is an old article from 1978, but it's one that I think about quite a bit because it was pivotal in terms of shifting the mindset of where people should be getting mental health care. And there had been a President's Health Commission on mental health. And at the time they found in 1978 that 15% of the US population had a mental health disorder, and only 1/5 of those people actually had received treatment in specialty mental health care, meaning that the majority of people, 3/5 were receiving care in primary care, and then 1/5 wasn't getting care at all. So that, then makes me think about what's the primary care shortage areas look like in the US. And there's still major problems. The South, and sort of rural, sort of Montana areas have major problems in terms of primary care. But in most places, there are at least some access to primary care and not primary care shortage areas. So, and then the same applies for Illinois and Indiana. Some areas are, some of the rural areas are major primary care shortage areas, but you still have pockets that are a little bit closer to find a primary care physician who could provide mental health care if able to do so. Here's another way of looking at same data. So this is data from the NANSES, the National Ambulatory Medical Care Survey, which does primary office visit surveys. So they go to office visits and they sort of open the charts and say, who did you take care of and for what conditions, and get information about individual office visits. And these are data that was published in 2015. And you can see that, and this is stratified by age, so younger adults and older adults, the total number of visits, so lots and lots of visits, the percent that had mental health diagnoses, 10% among younger adults, the 21 to 64, and 5% for the older adult age group. What I want you to focus on is the percentage of visits that were psychiatry or therapy visits. So 4% and 2%, 1% and 1%. So the majority of outpatient visits are not to psychiatrists or to therapists, even if a good number of people have mental health problems as their primary reason, and then lots of people are prescribed medications for mental health conditions. Also, as many of you know, depression screening is recommended as part of routine adult and adolescent care. So depression screening is recommended by the United States Preventive Services Task Force. And they do put the note that screening should be implemented with adequate systems in place to ensure accurate diagnosis, effective treatment, and appropriate follow-up. This is a grade B recommendation. It had been lower before, but it's been a grade B recommendation since 2016. So several years now. And this is another concept which I think is important to think about when thinking about primary care. So if we say primary care is the de facto mental health care system, how does primary care do in terms of taking care of depression? This is a great article by Brian Pence in 2012 that sort of describes the treatment cascade. So if you have 1,000 patients with primary care, how many actually achieve adequate care, and achieve disease remission? So if you go down this side here, you see that remissions only achieved in about 8 of those 1,000 patients, which is pretty unfortunate. And it's not totally related to the disease just being hard to treat. So about 12.5% or 125 people would be estimated to have depression. Clinically recognized depression would be 59 people, or about half. And what that means is that the primary care provider saw the patient, or someone saw, the primary care doctor saw the patient, or saw the patient in clinic, then they talked to them about their depression, they assessed it, they recognized that it was actually severe depression, not just something else, and then only 50% of those people get treated. So you're at 30 people now, and then many people in primary care are inadequately treated, started on a low dose of medication, referred to a therapist, but never get scheduled, referred to a psychiatrist, but never get in. And then you're left with 12 people who actually receive adequate treatment, and then only 8 who actually are estimated to achieve treatment remission. So the de facto primary care system, left to its own devices, is also not necessarily doing a great job of taking care of depression. So that brings up the idea of integrated primary care behavioral health models. And these models have been around for a while, and many of you may know their structure, but I'll just provide a very brief overview. So integrated behavioral health care is better care. What's the idea behind it? Many places function at the very least, maybe at coordinated care. So for example, a primary care physician recognizes that someone has a mental health problem, they refer to a psychiatrist or a therapist, and it's a one-way street. They send the referral, they hope that the person lands there, they wait for the person to come back to clinic and tell them what happened. The next layer up is something called co-located care, an opportunity for the behavioral health providers and the primary care providers to sit in the same physical space. Still referral based, so a person has a problem with depression, I'm going to refer you to our on-site therapist or psychiatrist, and at least they're down the hall. So you don't have to, the primary care patient doesn't have to go to a whole new place, something that's stigmatizing, go to somewhere they've never been before, something that feels a little bit more comfortable. That's what we call co-located care. And then integrated care is more integrated. So not only co-located, but also, you know, I can pull that mental health provider into the room and say, hey, you know, do you have a second? I want to see if you could talk to this person. They're a little bit they're a little apprehensive about seeing a therapist, but maybe we can convince them that's no big deal, and you could start to see them here today. So that's a warm handoff. And then collaborative treatment planning, where, you know, everyone sees each other's notes, so that way you know when the person has missed their appointment to the mental health provider, or the mental health provider goes, oh, you should talk to your primary care provider about that, and you've got an appointment coming up next week. You know, so that collaborative treatment planning, that there's good communication between the mental health and the primary care provider. So that's a brief description of what integrated behavioral health care is. And here's a more detailed example of the model. So I highlighted some aspects: co-location, some joint decision making, and then there's some structural things that are cited to be important: shared medication lists, shared treatment plans, shared problem lists, shared lab results. Those things are all super important, so everyone stays on the same page, and often is buoyed now with, you know, electronic health records. But, you know, sometimes behavioral health providers are behind a firewall. You can't see their notes, and, you know, so eliminating those types of barriers can help increase integration. There's also communication and collaboration, which I highlighted earlier, and sort of the shared trust, shared respect for each other, as having equal roles and importance in improving someone's health outcomes. So there's two major models of integrated care, and I'll describe them in more detail in the next few slides. There's the primary care behavioral health model. This is a model of care where you have a behavioral health provider, usually a psychologist or a social worker, alongside the primary care provider and the patient. And what the behavioral health provider does is it allows for someone to be co-located or integrated, you know, available via warm handoffs to help the patient as necessary. And the primary care provider and the behavioral health provider work really closely together. They're co-located, they communicate actively, they develop shared treatment plans. Unfortunately, there just have not been as many studies about this model of care. It's much more common than collaborative care because of the scarcity of psychiatrists. But unfortunately, because the behavioral health provider provides direct patient care with individual patients, they can have a smaller population impact just because of the limits of the number of patients that they can see. I was very excited to see this article that was published this year in the Journal of General Internal Medicine. That was the first very robust study of this primary care behavioral health model. And what they had done was they had actually integrated six separate sites, behavioral health providers, and they were in 6 different sites within this integrated primary care practice. And they were able to look at the rates of emergency department use, hospital admissions, and rates of primary care visits and behavioral health provider visits. What they found was implementation of this model was associated with reductions in the rates of outpatient emergency department visits, 14%, which is quite good, and actually reductions in primary care visits, but actually increases in behavioral health provider visits, which are, you know, all in the direction that you would hope the outcomes would be. What I wanted to highlight, though, was how many patients they needed to actually demonstrate this. So they required, you know, it was an observational study, but they had to, you know, they had to have 7,000 patients who had interacted with one of the behavioral health providers in order to find this effect. So, not surprisingly, that it's been hard to study this model of care and show its effectiveness. But I was very excited to see the study results, because up until this point, you know, lots of people would say, well, there's another model of care, but we don't know, we don't have very much data for it working. This other model of care called the collaborative care model has been very well tested. A lot of work from Dr. Wayne Caton, who is no longer with us, but over 80 clinical trials of this care model. And so this care model, what it does is it adds two people to the model. So not just the primary care provider and the patient, they add a psychiatry consultant and a behavioral health care manager, often a social worker, sometimes a nurse. And the behavioral health care manager, frequently contacts the patient, usually via telehealth, phone calls or video visits, and then contacts the primary care provider with any recommendations or follow-ups from the patient. And the behavioral health care manager talks with a psychiatry consultant about once a week, usually about problematic cases, patients who aren't getting better, changes in scores, and they do all they emphasize measurement-based care, which is using brief assessment tools like the PHQ-9, the Patient Health Questionnaire 9 questions to assess depression, or the GAD-7, 7 items to assess anxiety, to sort of assess how people are doing, if people are getting better, and then talk with the psychiatrist or the primary care provider if people are not. This model of care has been shown to be cost effective in a few years. As of a few years ago, Medicare and the subsequently private insurers covered this care model with billing codes. The meta-analysis of this care model of 74 randomized controlled trials assessing the effectiveness of collaborative care for depression. They found improvements in depression symptoms, a decrease in scores by -0.28. So not a lot, but across lots of people, it does translate well. And then increased antidepressant use with a relative risk of 1.5. That was published in PLOS One in 2014. Okay, so now I'm going to turn a little bit to talk about University of Chicago and the need for integrated primary care behavioral health at University of Chicago. And so this was a case that actually spurred my interest and desire to tackle this problem. This is a patient in my clinic. Some of you who I can see in the audience have heard me talk about this patient before. She's a 57-year-old woman with what I thought was depression and chronic pain. I just started seeing her, and in my few 20-minute visits with her, I didn't have a whole long history that I do now about her. She called me on my research office, the one you heard just go off, asking to see a psychiatrist. In between our appointments, not at an appointment, she just called my number, called the hospital, said, hey, I need to talk to Dr. Laiteerapong, and they patched her through to my office, and I picked up the phone, and she's like, I need to see a psychiatrist. I asked a few questions, and I said, okay, sure. I knew she had a history of depression and chronic pain. She said she wasn't doing well. She wasn't having suicidal or homicidal ideation. She was just I just want to see a psychiatrist. So I placed the referral in the system, and I patiently waited for her to get scheduled, and she didn't get scheduled. She called me again on the same number 3 weeks later. At this point, she was really distressed, and she told me she wanted to kill her daughter. She had a plan. She was sitting outside her apartment. She was waiting for her daughter to come home. As a primary care doctor, that's, being a panic symptom inside me. I called 911. She knew that this was not rational thinking. She wanted to get help. She went to the emergency department here at the University of Chicago. I went to see her. She was doing fine. She was thankful that she felt like she was in a safe place. She was happy to be admitted, wanted to get hospitalized. But because she had chronic pain, she wanted her pain medications. I left before this happened, but they wouldn't let her get into her bag. They said, no, you can't take your medicines. It has to be ordered by the doctor. And she got really agitated, very upset. Something happened, I wasn't there. And then they ended up using some chemical sedation, so that way she wasn't trying to get out of bed and leave the emergency department. And she got transferred to Mercy Hospital for psychiatry. Then she developed shortness of breath. She probably had aspirated, some stomach liquid had gone up her throat, and she got into her lungs during her combativeness in the emergency department, and she ended up having to come back to the University of Chicago to the medical ICU to get treated. And I visited her after she got discharged from the medical ICU, and she was very upset at that point and being like, I have no problems with my mental health. I just need to leave, your hospital. So that was a very motivating case for me to get a group of people together. And this is the group I got together. Some people have added and moved on over the years because this started back in 2014, but we formed the Primary Care Behavioral Health Integration Program. There's a multidisciplinary group that has been meeting monthly since December 2014, really focused at trying to brainstorm and solve issues related to mental health care at the University of Chicago. So I have the titles emphasized here because I think that's the novelty and the uniqueness that has allowed us to be successful to date. So I'm a clinical investigator the majority of my time. We also have Dr. Vinci, who's a medical director for the primary care group and also associate vice chair for ambulatory operations. There's an outstanding clinical educator and quality improvement expert. Also, Dr. Ari, who's a primary care clinical educator, specialized in addiction medicine and opioid use and opioid use disorder. Dr. Daniel Hanna, who's the chair of psychiatry, has had experiences in behavioral health integration and collaborative care. Dr. Beckman, and then Dr. Arujo, who's our health psychologists and outstanding faculty and champions of the primary care behavioral health model. And then Aaron Staub, who is my right hand research specialist in mental health, outstanding training, MPH, and has led a lot of papers and analysis for the program. So this multidisciplinary team coming from our unique angles of the world and experiences, and just doggedly pursuing improved primary care behavioral health integration at the University of Chicago. So our vision has been for many, many years what we describe as seamless physical and behavioral health care for the University of Chicago community. And it is broad, it's a broad vision, it's aspirational, and that allows us to flow from year to year in terms of our objectives and how we spend our energy. So what does we call it Primary Care Behavioral Health Integration Program, or BHIP, do? So we do 5 different things. We provide resources and education. We work to increase access to mental health care. We work to systematize depression screening and management throughout the medical center. We're actively implementing the collaborative care model, and then we do evaluation and research. So at a high level, the resources and education, what do we do? So we support primary care providers in identifying and managing patients' behavioral health needs and try to increase comfort levels, taking care of the more basic mental health problems. So that way we can reserve our psychiatrists who are in short supply to take care of the more severe cases. We also send out weekly tip emails. This is led by Aaron to empower providers to manage behavioral health more effectively. And then I lead the development of EHR innovations for U Chicago Medicine, specifically around the behavioral health piece. So here's an example of one of our clinical decision support tools. They are single page, made on PowerPoint with lots and lots of editing and micromanaging to get everything perfectly even. What we try to do is make it very easy for providers to use. So every clinical decision support tool is just on a single piece of paper. We try to highlight what screening tests we recommend, things to look out for, other mental health conditions to screen for. What do you do with the screening score? How do you triage someone's symptoms? And what do you do differently based on how severe someone is? Provide recommendations for medications. And then how do you actually follow up and monitor people over time? So for this is the one for depression. We recommend the PHQ-2 or another tool, which I'll talk briefly about, called the CAD-MDD, which is an adaptive test that Dr. Robert Gibbons developed. If someone has a positive screen, you should be concerned for homicide, suicide, or psychosis. The positive screen should be concerned about suicide, homicide, or psychosis, and consider using a different screener or doing something else. Complete the PHQ-2 to do a PHQ-9, and then depending on the severity of symptoms, you might be recommended to just provide patient education, provide therapy and patient education, start an antidepressant, or refer to psychiatry. And then we had, evidence-based recommended treatments. What class are those treatments? SSRIs, NDRIs, SNRIs. What are some things to look for in terms of drug interactions, side effects, price of these drugs, etc. These documents have gone through many, many iterations over the years with collaboratively with the Department of Psychiatry, whoever the champion is in that area. We bring those people in to sort of edit our documents, and then we push it out into the out there into the world. And we have many topics that are available now, not just depression. Here's an example of a brief screening tool. So we try to take, we look at all the different screening tools that are available. We try to pick the one that is both brief and highly, appropriately sensitive and specific to the condition. And then we push that one out, trying to make it very easy to use for providers and for patients to fill out. So sometimes trying to work on formatting, making it look, have big font, making it easy to understand how to score it. And we do that across a number of different mental health topics. Then we created dot phrases. This is information borrowed from our health psychologists. So Dr. Rougeau and Dr. Beckman provided the guidance for the contents of these documents, but they're available in our electronic health record under easy to use smart phrases. So if you type this little smart phrase.pcg-bmed grief, a ton of information, introductory health psychology tips around grief would show up. And we have a number of different available topics that are available throughout University of Chicago's EPIC electronic health record. Additionally, we provide patient education tools and handouts that are put within our clinic in little bins, and we constantly refresh and update them. They're also available on our website, so which I'll talk about in a minute. The other educational resource we do is send out a weekly tip email, which goes out every Friday for about 5 or 6 years now, and they feature information about our team's efforts, new tools, community resources, and also we sprinkle in some self-care there because we know that burnout levels are high among healthcare providers, mental health providers, and self-care is a huge part of being able to take care of other people. And this is an invitation for you to sign up for our weekly tips. If you're interested, you can just email me, and Erin, as I said, manages that, and we'll get you connected. It goes out to several hundred people now on a weekly basis, and I haven't heard anyone decline them. And then we disseminate information a couple different ways. We have a website which is featured here. It's one of the voices pages at University of Chicago. And so this website has our screening tools, our clinical decision support tools, our patient education tools. And we also send out tweets. So if you're a Twitter person, you can follow our Twitter handle, UCM-BHIP, and see the information from the weekly tips. So in addition to education resource, primary care behavioral health integration program focuses on improving access to care. So while we do solve individual cases related to referrals and scheduling, we also advocate for increased behavioral health providers, and then develop and maintain a network of community behavioral health providers. And that's the part that I'm going to feature among the different things that we do related to access to care. We, Dr. Rougeau and I have reached out to different community therapy partners and some psychiatry partners in the community and explained to them our situation. In South Side of Chicago, we're in a mental health desert. We would love it if we could partner with your clinic so that way we can allow easier access to mental health providers for our patients. And in exchange, we have a two-way street of communication. So if you have a problem with one of our patients, you know who their primary care provider is, and we could talk to each other, and we will try to send you referrals that are appropriate to your group. So what insurances do you accept? What conditions do you see? What conditions do you not see? Tell us when you're close to new referrals and we'll take your name off the list. Tell us when you're open to referrals or have a new therapist who's joining your group, and we will push and encourage our providers to refer to your practice. This has been an outstanding resource and a good partnership. We have about 18 partners now, because not only do we just send the name, we send them information, like why is the person being referred, and ask people, do they want telehealth or in person? What days of the week are the person available for therapy, etc. And it's been a good way for us to know if patients actually say yes, but it's a yes, no, yes, I'll see definitely, yeah, I'm interested in mental health care, but then, no, I'm not gonna actually call that person. I actually am not interested, but I just need to get out of this room with this doctor right now. But the next thing I'm going to turn to is depression screening and management. This is another big part of what we do, which is implementing protocols at the University of Chicago to improve depression care and then supporting institutional requirements for quality measures. And I'll just highlight the informatics tools that we've developed. So we have 3 different tools in our electronic health record to focus on depression. One is for screening, the next is for surveillance, and the last is for monitoring. Depression screening is for people who have no history of depression, never screened positive for depression. So an assessment that's brief and easy, like the 2-item patient health questionnaire, is adequate to assess if someone has depression or not. And if someone responds positively in the first 2 questions, then it reflexes the remaining 7 questions, and people get screened in our health system once a year for depression. People do have a history of depression, they would fall under surveillance, meaning that the PHQ-2 may not be enough to define if someone has depression, because they may have partially treated depression, and the 2-item PHQ may not be enough. So for those people, our system does a PHQ-9, so the 9 questions, and it's done once a year if someone screens negative. If someone screens positive for the PHQ-9, or their most recent PHQ-9 was greater than 10, then they could fall under monthly depression monitoring. So every month, the electronic health record, when the person comes to clinic, says that the person's due for a PHQ-9. There's tracking systems in the electronic health records, something called care gaps. If you receive care at the University of Chicago, you see it in your My Chart as a health maintenance activity you were due for. So for example, this is a person who is due for depression surveillance because they have a history of depression. You, as a clinician, when you go into the record, you'd be prompted to complete a PHQ-9, and then you can see here if the person screened positive for depression, they would next be due for depression monitoring. And then we also have this programmed for adolescents using the PHQ-9 adolescent version. This is what the form looks like in the electronic health record. So you have the first 2 items, asking the classic PHQ questions. And then if someone screens positive, then the rest of the questions come up. So this person's, and for us, we use a cutoff of 3 or higher to reflex the remaining 7 questions. And then very briefly, I already described in great detail the collaborative care model. So I'm just going to highlight here where we are now. We launched the program in 2021. We currently have 3 LCSWs who provide care management and or brief therapy, depending on what the patients need. And then, of course, consult with the psychiatrist weekly about cases. We currently have 3 different programs, one for adults with depression or anxiety, defined by their PHQ-9 or GAD-7 scores, and that's located in the DCAM Primary Care Group Clinic here in Hyde Park. Then we have a program for adolescents, 12 to 18, while they're in high school for depression or anxiety, and that's rolled out throughout pediatrics, and that launched just about last month in April. And we have a new program that is first that I've heard of, which is a program for older adults with dementia or cognitive impairment and some sort of neuropsychiatric problem or depression or anxiety. And that's a program that is launched in the primary care group here on campus, the Department of the Neurology Clinic, and then also the South Shore Senior Center. So we're really excited for these programs. We're starting our evaluations of them now to see how that they've been doing, and have plans here at the University of Chicago to grow those programs so that way in the near future we'll have collaborative care throughout the care network in primary care. Excuse me. And then I'm going to speak briefly about research and evaluation. There are several areas of research there that I could talk about, and I'm going to focus on the first one called the Portal Depression Study, because we have a lot of information about that I think will be interesting to you all. There's some other things that we've done. We've measured the changes in level of behavioral health integration in our clinic, perspectives of our providers. We've assessed depression screening disparities. We've analyzed our psychiatry wait lists and different predictors of wait lists. And we've also assessed a new tool, the Academy, which I mentioned briefly earlier, in terms of its effectiveness compared to the PHQ. We've also integrated it into the electronic health record. And the reason we, and so these are just some areas of further exploration and evaluation. And I'm talking mostly about the portal depression pragmatic trials that we've launched. The goal of this trial was to really get at the problem of the depression treatment cascade. So as I mentioned earlier, you've got 1,000 patients who in primary care, and you have a 50% drop off between the patient having depression and the person having clinically recognized depression. Our hypothesis was that, even when people come to clinic, even if you have a protocol to screen patients, that only gets people who come to clinic to get them to be clinically recognized. But there are a lot of people who when they're depressed, they don't come to the doctor. They're suffering, they're not motivated to schedule an appointment. They have, they're just suffering at home by themselves, trying to, make it day to day. So our hypothesis was that the patient portal could be used to reach into people where they are at home and bring people into care who might have depression, and compare that to usual care. And, we might be able to find more people with depression using the patient portal as a population health strategy. So these were two pragmatic trials that we ran pre-COVID and then during COVID. The two trials were similarly organized. One was focused on people with no history of depression, and the other one was focused on people with a history of depression. We ran the screening trial first, and then what we called the monitoring trial later. The way the trials worked was we had usual care, which is the system I described to you. So an alert in the electronic health record when a patient was due for a depression assessment. At the clinic visit, a medical assistant would administer the PHQ or the CADMH, the adaptive test to assess depression if the patient was due for it. And depending on the patient's results, if they were positive, it would go to the primary care provider who would deal with it during their visit. And that was usual care. The population health arm was everything that usual care was, except regardless of if patients had a scheduled appointment, they would get invited to complete the adaptive test for their mental health assessment online, whether or not they had a scheduled appointment. And the results would go back to the primary care provider in between, whenever they were filled out, even if the person didn't have an appointment. So a population health strategy, as a primary care provider, I feel like I'm responsible for people even if they don't come to my clinic appointments. And so I'm gonna worry about them even when they're not coming to see me, and I'm gonna try to figure out if they have depression. If they do, they need more help, and I'll reach out to them. The trial, they were large. So our screening trial had about 700 patients. Our monitoring trial had about 1,400 patients. Actually, I worry that those ends are not updated. They were large trials, and the demographics were the same. There are no differences in by randomization. This is an overview of what we found. So this is the depression screening rate from the screening trial. And these are obviously pie charts. You have the population health arm on the left and the usual care arm on the right. And what you have in the different colors are the depression screening rate. So the dark gray for both of them are no screening at all. So what you can see just off the bat is the population health arm had 57% screening rate compared to the usual care arm. So definitely more screening, and 20% of, and then among the screening that was done, 18% of that was via the portal, and 25% of that was via clinic visits. So patients were still coming to clinic in the population health arm. It was sort of an 8% difference between the two. So in the end, you have 10% of patients received screening via the patient portal arm, and by the population health, in the population health arm, so 10% more patients got screened in that arm. And then for the monitoring trial, this is the depression assessment rate. Again, you've got usual care on the right, population health on the left. In dark gray, there was no assessment at all during the 1-year study. You can see that many more people in the population health arm got an assessment, so about 41%, so versus 82%. And then 40% of those people did the assessment via the portal, at least one assessment. This trial was run during COVID, so we had the benefits of people feeling more comfortable using the patient portal to interact with the healthcare system and provide personal information. And then in the pinkish colors, those are the people who responded via the, who got assessed at least partially at a clinic visit, and those visit rates were the same. The other thing that we noted was that in the screening trial, there were higher rates of depression severity in the population health arm. So this was our hypothesis, that people with depression might be suffering at home, and that they might be interested and willing to have the healthcare system reach into their homes and identify them and get them help. And so what you can see here on the y-axis is percentages between 0 and 10%. On the x-axis, you have different levels of depression, so mild or moderate or severe depression. The green is the population health arm, the purple is usual care. You can see that both for mild and moderate or severe depression, there were higher rates of people who had the condition, had depression than in the usual care arm. And so suggesting that people in the usual care arm were, they shouldn't be less likely to have depression, but they were less likely to report their symptoms because they were, just being assessed when they come to clinic. So the population health arm was probably closer to the true rate of depression, but many of those people weren't going to the hospital, weren't going to their clinic visits to get assessed. So the conclusion from those findings were that depression screening via the portal could increase screening and case identification, but low response rates could affect portal depression screening. And the patient portal can be used to support population health approach to depression screening assessment, reaching in to patients who might otherwise seek care, and leveraging protocols and IT solutions could be helpful. And then overall, I hope that I've talked to you some about the major shortages of behavioral health care access, helped you identify that primary care is the de facto source of mental health care, and that integrated behavioral health is an effective strategy to improve behavioral health, to improve mental health, and that our model is innovative in its emphasis of empowering primary care providers, developing a referral network, as well as using more conventional strategies like collaborative care and the primary care behavioral health model. And in our vision to create a world with seamless primary care or physical and mental health care for the University of Chicago. And that's my talk. Thank you.
That's great. Thank you. It was super interesting. It looks like we have a question, but I think I'll go ahead and kick off with my own question, and then we'll ask a question from David in this. Yeah, I just appreciate the kind of overview of, all the different research projects you have in this area, and also giving us the overview of, how severe the shortages are across the US. That was really helpful. So given that, I wondered if I wanted to start by asking you a question about the kind of the shortages. One thing you mentioned is that as part of this collaborative behavioral integrated health team that you've put together at University of Chicago, which is super impressive, that one of the things you do is advocate around, addressing the shortages. And so I was just curious if you could talk a little bit more about that. Like, what are you doing in terms of advocacy? What does that look like? And yeah.
Oh, that's a good question. I didn't talk a lot about that. Things like finding a payment model that works, like collaborative care, when it gets, we were advocating for collaborative care for years before there were, billing codes, and that got us nowhere because who's going to pay for it, And then when we got billing codes, it became easier. Some of it's around, like providing data to the department on how many behavioral health referrals they have, what the wait list is like, analyzing the wait list, how many people are referred and not scheduled. That type of information is really important for driving the argument, for the clinical need that can get pushed up to advocate for more positions. Let's hire more social workers to provide long-term therapy in our department. This would be the need. They would fill up really quickly. And so there's a need there, and then they could bill. So there's been some internal advocacy for the Department of Psychiatry that I've been able to do by using my research skills to analyze data, very messy data around, the rates, you're getting visit level, encounter, referral level data, trying to decide, well, what's the wait time? It's very complicated analytics, actually. Who gets scheduled, who's canceled, who's, that sort of thing. So we've done some internal advocacy around that. The other part I would say is understanding mental health care. Like, what is it? Like, I could tell you as a medical doctor, you get very little education on mental health, what's a mental health carve out? Like, that concept, was nothing I'd ever heard of before for insurance. And why is it that why is it so hard to get a mental health provider? And then that allows you to, what are the different types of mental health care? That allows you to sort of understand the spectrum better, so you can advocate for patients better, and then advocate for the right partnerships that we've established in the community. So I could tell you as a primary care provider, no one tells you what an intensive it's very few people who know what an intensive outpatient program is. And then, so when a doctor is talking to their patient, they can't explain it. And then the patient didn't need it. But as soon as I learned that we needed it, then I advocated for a partnership with the intensive outpatient programs in the community, so that way we can provide people the right level of care. So there's this advocacy piece around trying to identify good, high quality partners that we could partner with and maintain those relationships. And then simply, understanding that we're an academic medical center, and we cannot be responsible for providing all the mental health care in the South Side of Chicago. So, supporting the community therapists who, they have a small shop. They're, they want to be full with patients. They don't want to spend their money on advertising. They don't want to spend their money on patients canceling appointments and not showing up. So there is some, I consider advocacy to identify and maintain these partnerships, so that way we can create a streamlined system for both parties to actually, maintain their practices and then help our patients. So some of it's around, at the University of Chicago, trying to gather more resources and make an argument for more resources. And some of it's trying to help the community get more patients, so that way they can grow their practices. Several of our partners have managed to, add therapists to their practices because they have a constant stream of referrals. And that's very promising for them.
Yeah. No, that's really interesting. That seems really, really useful. Let's see, let's go to David. Innes had a question. The first problem with getting people into the system, sorry, let me read it over here. Are there AI tools for non-health professionals? Obviously, his examples are school social workers, police department staff, staff at senior centers, and other social welfare organizations. So are there AI tools for non-health professionals to identify mental health problems that require a referral? Do you know of anything like that?
Thinking. I don't know if any AI tools. I mean, the brief assessment tools are pretty, the brief screeners that I mentioned a little bit of are all available and can give people a sense as to if someone has a mental health problem. So the PHQ-9, the GAD-7, there's PTSD screeners, there's substance use, the audit. There's lots of brief screeners that are already available that you could take on your own. If you're like, I don't know if I have a problematic drinking, just fill it out. I mean, they're all meant to be self-assessments. They're not meant to be delivered by someone else to you. And so, and then using those tools, there's publicly available scoring systems for them. People can go on our website and take this, download the screener, look at the clinical decision support tool,
Mhm.
and sort of be like, oh, look, this is where that person is. I'm kind of worried about that. We tried to make them as simple as possible. And they are freely available and evidence-based. So in terms of artificial intelligence tools, I think of AI tools as sort of being, very self-directed, hands-off, like you go into the system and it sort of figures it out, that can answer some questions. I don't know if that's the same as of what we're talking about, like adaptive tests, which are different. Adaptive tests are just questions that you would answer, and the questions order changes, or the number of questions you need to change the number of questions you need to answer changes depending on how your responses go. And that's Robert Gibbons's tool, the one that Nicole is mentioning. But even for that, the different tools are separate still. So you'll have the depression tool, you'll have the anxiety tool, you'll have the PTSD tool. They're not all yet, I'm sure it's something we would love to have, all built in, so you just answer one question and it brings you through all the different paths. If you have to take 5 different adaptive tests, you're going to still have a lot of questions,
Right.
So a lot of our screeners in primary care, we have like the 2-item screener first, and then if you do score high in that, go to the remaining questions.
Yeah. I wonder, just the question about AI reminds me of, at the University of Chicago, there's the JCOIM project, which focuses on, OUD and justice-involved populations. And I think they've been doing AI work around just sort of predictive analytics to try to figure out, are there, can you predict where there would be high levels of OUD in neighborhoods and in communities? And so it might help you target the portal screener a little bit more. I'm kind of thinking out loud how AI could be useful in thinking about also identifying people with potential depressive symptoms or mental health problems.
Yeah, I hear you. The most interesting part of one of the most interesting things from the portal work is that the self-insight into that the state is not normal that someone's in varies. So our original first round of the population health arm, we said, oh, well, if someone scores high on the lots of symptoms, we'll just have our schedulers reach out and schedule them for appointment. And there were so many people that were like, why are you calling me? Like, to them, their state was normal.
Yeah.
Just how they are, They've been suffering at home. They had no insight to the fact that other people aren't experiencing the same level of severity. So I worry a little bit about AI tools, predictive analytics. Some groups in the population are much more comfortable describing their mental health problems than others. Socialized, so more acceptable for some groups to report mental health problems, and that gets baked into our predictive analytics.
Right. No, that's a really, really good point. Samuel Bethel has a question here too. He wrote, I have a question about integrated programs and sustainability. For example, LCSWs are well gotten for care coordination and direct provision of psychotherapy, but receive the lowest reimbursement rates for mental health services, often 75% of the physician fee schedule, which is the lowest reimbursement among all licensed healthcare professionals. Is sustainability an issue in these programs?
I hate the physician fee schedule. It's just so not fair. Another great example is like dietitians, who could probably provide the best advice for how to eat healthy. They can't get reimbursed for recommending people to eat healthy, but physicians can, and we get like probably the least training on how to do it. So yeah, this is a problem. For the collaborative care model specifically, they use different codes. You don't need an LCSW to build the codes. You can have someone who's master's trained, and that obviously will save money, though the person will be less skilled. We have chosen to hire LCSWs for the positions that we have here because our patient complexity is high, and we're also kicking off the program, and so we start something new. You'd rather do that, but I think most places don't have, many places don't have the complexity of patients that we have. A lot of people are using master's trained people for these roles. Also, the number of patients. So the number of patients one of these care managers can manage usually averages 60, can go all the way up to 120. It can be quite high depending on the complexity of the patient. And so you can kind of, increase the caseload. I mean, we're not doing that here because, because of the patients we're taking care of and sort of our vision and our goals. But there are ways to make it sustainable. I ran an internal analysis of the cost effectiveness of the program. And with an average LCSW salary and someone doing 80% of their time doing direct patient, like doing patient care billing with the collaborative care codes, they break even to turn about a $2,000 to $3,000 profit actually. So the codes themselves are well priced for the salary, but I agree that the job would be, it's not fair that LCSWs don't get paid as much as they should.
Yeah. Just on the payment issue, you've mentioned several times that the collaborative care model, Medicare pays for, there's a code for it now. I assume Medicaid also pays for it, or no, in the state of Illinois? So that's like a big problem, because I would assume a number of your patients are on Medicaid, no? Or do they not? Are you not able to see them because you can't bill for it in the collaborative care model?
So a couple notes on Medicaid. Actually Daniel Hanna and I think Dr. George Wire here actually advocated for like Blue Cross Blue Shield to cover these codes, and they do, and they pay for them in Illinois. And I think they also went to Medicaid, and there's a bill that says collaborative care has to be covered for Illinois, I think as a result of their advocacy efforts. But they forgot to, or someone forgot to actually put payment next to the coverage. So right now we have coverage, but no payment, which is really creative. And so I that's sort of like next on our docket. I organize, I have a couple of other people who are directing collaborative care, and we're talking about, we have different ideas of things to advocate for. And so that's like on my list of things. I think it's a big problem. Here at the University of Chicago, Medicaid managed care opted to drop its primary care contract for adults. And so that was last year. And so, or maybe several years ago, actually it was right around COVID, when COVID hit. So it's been a couple of years. So for the hospital-based primary care practice that I practice at, we can't see anyone who's Medicaid only, which include, so county care, Meridian, all these care plans. We can see people with traditional Medicaid before they get into a managed care plan. That's very much related to our very high facility fees, being a hospital-based clinic, and the preference for a lot of these managed care Medicaid plans to have people who receive care at places without facility fees or directly within the county system. But we do see people in pediatrics and so collaborative care pediatrics, we're going to see them, we're going to bill Medicaid and not get reimbursed. For now.
Yeah, that seems like a huge problem. And the University of Chicago's decision not to take Medicaid adults for primary care is because of the payment rates?
No, it's the reverse is my understanding. Now, I'm not part of those negotiations, but Medicaid they couldn't come to an agreement, I guess I would say. Like I'm not a party to the conversations. I mean, the primary care physicians are strongly, would love to take patients with Medicaid. All the specialties take patients with Medicaid. My understanding is that Medicaid said that they would rather have, my understanding was that the county, they had lots of providers, primary care providers, that they could see their patients, that the patients were opting not to go there. And so we're hoping to shift people back over to Cook County for primary care from University of Chicago.
Okay. Interesting. So the other thing I was wondering about is I was just curious how, if you've seen in some of your analyses, any variations in terms of race or maybe age, some of these sort of demographic characteristics, and if you've thought about that at all in terms of, I know you're primarily focusing right now on screening, but are things happening differently by race, or?
Yeah, it's, part of what whenever I do a study, I always worry about, exacerbating disparities or hoping to reduce some disparities and outcomes, and think about health equity. So we have, for depression screening, before we implemented our medical assistants doing the assessments, it was up to the primary care providers to do them. And so we did a study that was published looking at our depression screening rates by sociodemographics to see if there was differences before and after the implementation of our medical assistant protocol to do the work. We did find that disparities decreased or flipped, actually. So populations that were younger, less white, were less, I think they were more likely to be screened, but then afterwards populations that were Black were more likely to be screened for depression. Our oldest age group, our Medicare and our oldest age group were still less likely to be screened, but better than before, and some other disparities went away. We think it's because our medical assistant population is predominantly Black women, and that probably helps comfort levels, and also the standardization of the practice also helps. Whereas before, our patients are not unequally sorted. So if a provider is a minority, they have a higher minority population than if they weren't minority. And then some of our minority populations have higher numbers of chronic conditions and other conditions. And so when the burden's on the primary care provider to do all the screening work, they may not have the time and they wouldn't get to it because they're doing other things. So we've done that analysis, and we also looked at the portal, using the portal for the population health intervention with the different demographics, and that's some work that Erin Staub led. And we did find that there were differences by race and ethnicity. I think it was Hispanic populations were less likely to use the portal. Our portal is only available in English, so that might be part of the problem. But Hispanic populations were less likely to respond via the portal. Younger age groups were more likely to respond to the portal, but we're not surprised about that. So we did find some interesting things. And so those are some of our recommendations are when we're using like the portal as a tool, you've got to think about the disparities that you're introducing.
Right. Yeah. No, that's really interesting and important. So you mentioned something about the portal that I wanted to follow up on because it seems really important, which is so people would, from the portal, you would identify people who have depressive symptoms or have are testing sort of positive, I think you said, in terms of mental health concerns, and then you would follow up with them, but they would say, why are you calling me? So I guess I had a couple questions around that. One is just sort of, what are your strategies in terms of follow up if people aren't reaching out, but you're following up? So how have you been thinking more about that? And then secondly, you're finding a lot more people, but we still have these shortages. So do you have this problem of finding a lot more people and then you actually can't help them, or how do you think about the next step as well?
So for the first problem, a lot of it, we shifted the model. So, if we identified someone, we shifted it back to the primary care providers being responsible for following up. And primary care providers, a lot of them have nuanced relationship with patients, and they can kind of tease it out and figure out the right strategy. They can individualize their follow-up. Sometimes they would say, we'll talk about it at our visit. Sometimes it was like, I'll reach out to them over my chart and figure out what's going on, the patient portal. Or sometimes it was like, that's something new for them. They should just, can you have a social worker contact them and get them plugged in? And so that worked pretty well for the patients, and fewer people were upset with the system. And the trials are over, and we're not actively doing this in our primary care clinic now. We're sort of we're planning actually to do put a grant in for a much larger multi-center trial testing these ideas, because we have a lot still to learn, I think, about it. And the quality measures aren't aligned to doing population health depression assessments. It's very like clinic visit based right now. So in terms of your second question, what happens when we find all these people? Where do they go? Some of it was instrumental to build the capacity in our clinic to take care of more complex patients with mental health problems. So we've had the advantage now of the resources from the team being available for several years, and people have gotten quite comfortable starting antidepressants, adjusting antidepressants, even such that referrals to collaborative care probably have lagged because they're like, well, I know how to start the antidepressant. I'm like, yes, but do you know how to? Are you going to call them in 2 weeks to make sure they took it? And they're like, oh, wait, that's true. Okay, let's have the care manager do that type of work. But, so I think that's been part of it, is sort of empowering the primary care providers. And it's been more successful for some conditions than others, like depression, anxiety, no problem. But adult ADHD, some are like, oh yeah, that's fine. I can screen for it. I know how to screen for it. I know how to think about it. I feel comfortable starting a medicine for adult ADHD. Others being like, no, you need a psychiatrist for that one. So there's some that, where the uptake was quite easy, some that's been harder, and, that's fine. And then the other part is these community therapy partners, like, have been totally essential. And I would say that partners have gotten full and then dropped off of our referral list, but somehow we've been able to stay ahead of the curve. The problem is, yes, if every major institution in Chicago did this, then I would run out of therapy partners, right? Because patients are definitely needing more therapists. We have leaned on mental health apps as a sort of bridging strategy, and also, we have our health psychology team. They the faculty have been teaching our trainees how to do better health coaching, motivational interviewing, and providing supervision for that. So I think some of it's like about trying to train providers to do more of this type of work, and then reaching out to partners, and then leading on technology like apps and stuff where we can. But you're right, and then something like expanding collaborative care would always be good. But there's also there's a shortage of LCSWs as well, or social workers. I mean, it's multi-level the problem shortage. So
yeah, absolutely. It looks like there's a question in the chat from Nicole Gear. She writes, working with the collaborative care model in our program, I often wonder how we can facilitate these approaches earlier in medical training, perhaps a collaborative care rounds for residents, a grand rounds series led by social workers, behavioral health clinicians, community therapists. Curious your thoughts on how integrating behavioral health care training might look earlier in medical training for an interdisciplinary team.
Those are great ideas, Nicole. I know Nicole's had the program first at University of Chicago and is, quite knowledgeable. I think there's always it's always about fitting it into the schedule. There's always so many things to teach.
Right.
I could tell you that the appetite is not strong to necessarily learn about this, except if you're in primary care as your job, then you're like, oh, wait, I needed that, I wish I knew more. But so many of our trainees are not staying at University of Chicago, are not staying in primary care. We train a lot of specialists, and but these models of care are effective. Like there's, in other specialties. So there's I was just reading a systematic review meta-analysis of using collaborative care in oncology, and how that's effective as well to improve mental health outcomes. So, Nicole, you and I could talk offline, but I think that it would take lots of conversations with people, and maybe hard to squeeze into the tight agendas, curricula, the residency training program. But I think there's other interested parties that could collaborate. I think something across the institution would be interested, across the hospital in different places would be interested.
Yeah, there's also a question here from Ashley DeGarmo, and it relates to another question that I had, so I'm going to kind of fold them together, which is that we use this term kind of integrated behavioral health in a couple different ways. And I appreciated that you kind of showed the continuum of the integration model. But the other way that it's sort of, that we use integrated behavioral health is sort of old now, but basically really emphasizing the need to integrate mental health and substance use disorder, right? Like behavioral health, that's the definition of those two things, but it seems we're still kind of working on making sure that that's tightly integrated, and then integrating with primary care. And so Ashley's question is, did the program also consider including excuse me, peer recovery coaches as an example, or, somebody who is a specialist at addiction medicine or addiction addiction care, right? A social worker as well could do that. Did you include them in your model or consider including them?
Not yet. I would say not yet. So right now I'm working on a couple projects around this issue of substance use. As I said, Dr. Ari is addiction medicine board certified. So we have her as sort of our liaison to that area. And she leads also the opioid consult service in the hospital for patients who come in and would benefit from buprenorphine or other medicines for chronic opioid use. So her insights have been very helpful. This is basically where we're going this year. So I've got a project in the HIV clinic, which is exploring how to do substance use disorder screening, get some patient feedback in the HIV clinic on how to do assessments in a culturally, in a sensitive way, and then also thinking about the linkage to care. What are the treatment pieces that we have within our health system, and what are we missing? What do we need from the community to build a addiction treatment referral source like we have for the the mental health problems that we have already. And then, so we're moving in that direction. We're also thinking in primary care about the same issue. So screening, patient education materials, we have some, but not all. And then how to make the linkages to care. So I'm thinking about both in the HIV population and the general primary care clinic, but there's so much work to be done. And, if we complain about the mental health shortage area around Southside, the addiction treatment in the South Side, it's like even worse. So in a lot of ways, it's so challenging, but we're working on it. Yeah,
I can imagine. Kind of along those same lines, I think there's, growing, there's been long time interest in thinking more about the social determinants of health. But I think, more recently, actual kind of implementation of thinking about kind of health social integrated models, right? And so, similar to what you described, there's sort of, you can start with a screen. So not only do you screen for behavioral health indicators, but you could screen for social risk indicators. And so I was curious if you all have thought about that as sort of the social risks also being related to mental health care risks.
Totally. Yeah, no, we're right there with you. That's part of our thoughts and plans, or thinking about bundling the screeners together in our clinical system. And like, how do you do that? How do you not ask like a million questions, right? Do it to the right number of questions. Keep in mind that our people who are filling out the portal stuff, I mean, that's a great way of doing it, but those aren't necessarily the people who are going to be responding positively or as positively as some of the other groups. But that's definitely something that the health system has been thinking about what to do about. But we don't have, and so I've been in a couple of meetings, but I don't think we have a clear plan yet for that part. So the question is, do we do it all at once, or do we kind of do little bits at a time? Because when you drip the parts in, then the person can answer 2 questions here, 2 questions here, 2 questions here, as opposed to you launch everything at once. Now you've asked 20 questions. Food insecurity, transportation insecurity, housing insecurity. I mean, there's several domains that you want to cover ideally.
Yeah. No, it's tricky. And no one's going to be happy filling out 20 questions. Yeah, absolutely. Well, I've one more question. We only have a couple minutes left. You mentioned these 18 partners and how helpful they've been. I wondered, are a lot of them located on the south side? I know it was interesting around your advocacy. You were saying you were able to really kind of try to provide support in terms of, funneling patients to providers on the south side. Or have you also partnered with, are some of your partners on the north side, or where are they basically?
Yeah, so most of our, we try to emphasize the south side. I would say about half of them off the top of my head are south side practices. Some of the other practices are practices from people who we know that have graduated, who, high quality. So one of the things is we don't partner with just anyone. Like myself and Dr. Rougeau meet with them. We kind of have conversations. She vets them for their skills, like what therapy practices are they using, what evidence-based models, how are they, she asks really good questions to try to figure out, are they doing something evidence-based, or are they not, and the quality. So we want to be able to guarantee the quality to some degree. So those are sort of the two groups of practice. And then I had been intentional about specific targeted groups where we know that we need more therapists. So trauma has been an area. So in the last month, I sort of focused my efforts on identifying places that sort of say they provide trauma-informed care, trauma-informed CBT, really specific. Now, those are hard to come by too, but and most of those are on the south side of Chicago, actually. So it hasn't been that hard to find, but groups that we never heard of that we should have known about. They're located in the Hyde Park Bank building,
Yeah.
but because none of, it's just, or I should have known about them at least. So, but yeah, trying to stay on the south side of Chicago, but we have some good partners on the north side, and we have, our patients do come from all over, but mostly in the south side.
Yeah, that's great, because I was just thinking that it introduces transportation issues and all these other concerns if you're doing a referral to the north side. So that's really great to hear.
Our biggest challenge has actually been Indiana, because of telehealth, you have to be in the same state providing therapy. Right. And so our patients in Indiana are the ones that are most challenging. And I haven't found great partners in Indiana because they don't come back for some reason quite yet. I'm working on it.
Well, you have a lot of things you're working on, and it's all fantastic. So thanks so much, Neda, for joining us. I learned a lot. I think hopefully everyone in the audience did too. So but good luck with your future work, and thanks again for coming.
Thank you for having me. I really enjoyed it.
Absolutely. Okay, take care. Bye, everybody.